Dr. Hugh Foy, who will be up to the podium next, is a professor of surgery at UW School of Medicine. He's the director of the Surgical Specialties Clinic at Harborview Medical Center and practices general and trauma surgery as well as surgical critical care. He's a faculty member in the UW School of Medicine Colleges system and heads the Wind River College. He obtained his medical degree from the University of Nebraska, completed his residency here at the University of Washington, a fellowship in burn surgery and critical care at Harborview Medical Center. Dr. Foy's clinical interests include trauma, surgical infections, gastrointestinal surgery, management and reconstruction of the intestinal tract, complex wounds and abdominal wall hernias, and he's been awarded the Margaret Anderson Award for his help and support of UW medical students as a mentor. With that, I will conclude my remarks and turn it over to Dr. Foy, and I just want to tell you, have fun. This is going to be a great series of presentations, and thank you again for your attendance.
We'll blast through some of this, but basically, here's my world. This is a picture of doing an operation on the intestines in the operating room, and it's usually a fairly fixed, small area that we're operating on, and obviously one of the biggest surprises, I think, to people is that there's really not a lot of blood, and we try to avoid that as much as possible. Well, the goal of this is to help you be a better teacher of technical skills and teaching people how to do things. And it's helpful if you appreciate why this is important. There's a whole host of reasons. Obviously, you don't want people who don't know what to do operating on you or your loved one. I'm going to give you a few principles of psychomotor skills teaching and how people learn or acquire them. And then I'll show you some principles and some tips to help you do that job better. There's a whole host of reasons why this is important. I mean, the obvious one is you want competent surgeons taking sharp objects to you to try and repair whatever illness or injury has rendered asunder. Society, believe it or not, has, in the old days, they just trust me, I'm a doctor. But as time wore on, you've seen the articles about ghost surgery, and it was true that a lot of teaching of technical skills in the operating room was in fact done by senior trainees to more junior trainees. And the fully trained surgeons, particularly at night, were oftentimes not around. Well, as the people who pay for medical care, the insurance companies, the government, and everyone said, hey, that's not right. We need the experienced people to be there. There was an obvious deflation of the resident experience, because if me, the attending, has to be there, well, I'm going to elbow somebody else, and there's only so many people can stand around that small operative field. So over the last 25 years, there's been this steady deflation of hands-on student and resident experience. At the same time, we've seen an explosion of technology, all this minimally invasive surgery done with cameras, long-handled instruments, in not a three-dimensional or almost four-dimensional environment where we can see it, we have depth of field and depth perception, but we can feel the tissues. Now it's two-dimensional on a screen. So a technical explosion, particularly in cholecystectomy or when we taking someone's gallbladder out, which is one of the most common of all abdominal operations. And there's always the expectation of technology that, hey, computers can do all this. You can teach somebody, and the analogy is always about flight simulation. Well, shoot, they can teach people how to fly an F-18 or a Boeing 787 on a simulator. Why can't you do that in surgery? And for any of you who have ever handled live organs, it's the most unusual experience of your life. I mean, they are so different than anything you've ever handled. So the tensile strength and everything, and the computer power that's necessary to reproduce that deformability and softness of tissue, as well as a whole host of other things. And that feedback when you can feel it, or what the scientists call haptic feedback. And there are research projects where they're actually working on gloves to be able to feel something in a virtual or almost robotic environment. But it takes an enormous amount of computing power, as you would think, to do that. And those robotic surgical arms that we've shown here in years past are millions of dollars. And you know, they're very delicate instruments, so they break all the time. And limited resources, I don't think any of us would disagree that there's less money in healthcare than there is tonight. You know, we can't count on that for tomorrow, you know, particularly in these challenging times. So these things are expensive, and I just don't know how sustainable they are. Many times we get support from different companies that make the instruments and everything, but anyone who's had any experience setting up technical skills labs knows that that support can be very fickle. That can be gone in a fortnight, and you're left there with a bunch of broken, expensive equipment. Up until about 10 years ago, there wasn't much written at all how to do this. But in the last 10 years, there's really been an explosion of research and scientific writing about, well, how do people learn these technical skills and how do we best teach them? And we've got an excellent lab here at the University of Washington, and throughout the country, a lot more research and a lot more has been written. When you think about doing technical skills, it's a lot like competitive sports or any complex sport where you're using your body with an equipment that interfaces with a changing environment. And it really, the principle is that you've got to be very accurate, but at the same time you've got to be moving, because it is something that you do with movement. There's got to be an economy of effort. And also you've got to be adaptable to a changing environment. Now this slide shows my wife's skiing down this, what looks like a beautiful field of pretty consistent powder, is in fact about a foot of blown-in powder in these ice-hard moguls. And so every time she'd hit one of those moguls, it would throw her. And if she's not flexible and bent at every joint and adaptable, she's going to very soon land on her nose. Same thing in the environment in the operating room. The tissue's tensile strength can change dramatically from one layer to the other and so forth. The process of inflammation can turn a routine operation into nearly a nightmare because things are swollen, they're very bloody, and they can just fall apart with any misstep. Well, there's some characteristics that distinguish motor skills from verbal skills. They represent a chain of responses. You've got to do one thing and then another thing after each other. It's like that cartoon where the guy's getting out of bed looking at the sign on the wall that says, pants first, then shoes. Right? You've got to do them in that order, or it just doesn't flow smoothly, and sometimes, in fact, it's impossible. And it requires eye-hand coordination. You know, that we're trying to be very open-minded and very inclusive about having people with various different physical disabilities being able to live and work in our environment. But I really don't think, even though I've seen blind skiers before, believe it or not, on long leashes, I don't think we're ever going to get to the point where we're going to have blind surgeons. Now, to be truthful, sometimes when we can't see, we do a lot of operations by feel. And where we're down in a deep place where it's just impossible to get to, sometimes, as Obi-Wan told Luke, see with your mind, Luke, not with your eyes. And we actually do a lot of operations by feel and not by sight. But there's these organization of subroutine. When we sew or we're stitching two pieces of intestine together, we put in the stitch. I always tell the residents, push, put the needle in, push it, re-grab it, and go to the next one. And then when they tie the knot, as we saw in the demonstration with the students, and then the knot has to be cut. So a good scrub tech, the person that stands next to us, knows that that subroutine's just going to happen that way. Well, there's some conditions that help make learning more efficient. And there's contiguity, which is a tad bit of a weird word, There's practice and there's also feedback. And here we've got some residents working in our animal lab doing a laparoscopic cholecystectomy. They're taking a gallbladder out of an animal that has been anesthetized, is under general anesthesia. Contiguity is very interesting. It means doing the same thing in close chronologic sequence. So, any of you know how to water ski? You ever got up on a slalom water ski? How many times did it take you?
7 or 8.
7 or 8 times, right. Hard, wasn't it? And did you do 7 or 8 in a row, or did you do 2 times and then came back the next day, did another 2? In a row. See, if you went out and tried it once, just like, remember when you learned how to ride a bike? If you tried it once and then you came back a week later, tried it again, you can't use your learning from your prior failed experience to correct what you're going to do next time. So contiguity means doing it in close chronologic sequence so you can utilize your experience and your learning from your failed attempts or your near misses before. And obviously practice, doing it over and over and over again. I mean, it's annoying to have to change my 8-character password for certain programs every 3 months. Now the one I don't have to change, I've got my motor memory, I can just whack that out. But the one that I've got to change every 3 months, I keep struggling. Just about the time I get it down fast, it's time to change again. So there is motor memory that you get by practice. And the way that you initially get better with practice is feedback. When you learned how to ride a bike, who was there to help you? Did you go out and try it yourself? No. Your dad or your mom or your big brother or big sister, they came out there and pushed the bike so you could get going. And when you fell over, they brushed you off and patted you on the back, said, don't worry, come on, everybody falls. So you need an experienced person to guide your attempts and give you feedback, Say, don't worry, the faster you go, the better you'll be. Don't move the handlebars so quickly. So feedback is an absolutely essential piece. But it's expensive because you need experienced people around to put the time in. There are also phases that you have to go through. And the first one, obviously, is the introductory phase. You show people the equipment, they get used to it, you tell them why it's important, you give them a demonstration, etc. And then you let them practice. And then, like this resident in the skills lab taking a rubber gallbladder out of a much cheaper model, you just let them practice and practice and practice until they get more adept, if for nothing else, holding those unique, really long-handled, awkward instruments, which are much different than the instruments we use when we do open surgery in the operating room. Again, the introductory phase, the first and most important part is that needs assessment. So you've got to know where you're starting, or you're either going to shoot too high and you're going to overwhelm someone, or you're going to shoot too low and you may run the risk of insulting them. First you got to know where you're starting, and the best way to do that is just ask a question. You introduce the objective, explain the rationale, show them the equipment, and then demonstrate those sequential steps. As the resident's doing here, a senior resident on the right with a junior resident. And they've gone through all those things before they started the operation. Well, rather than show and tell like kindergarten, it's kind of tell and show. First you tell them, and then you show them how you do it smoothly so they see it can be done. Okay, if they don't see that it can be done smoothly and easily, they don't believe you, because the first attempts can sometimes be so difficult. You've really got to kind of coach people through those kind of critical steps and show them around those little pitfalls. In order to do that as an instructor, you've got to analyze that movement in your own mind. And you've got to think, well, how do I do it? And you've got to back up and think, well, how would I tell somebody how I do that? Which can be very tough. Any of you ever been in the military? In the military, you take these aptitude tests during basic training to try and figure out if you should be a tank driver or a jet pilot or a clerk or whatever, and there's these mechanical aptitude tests that you have to take. And a lot of them are these folding of shaded boxes. And you're given a shaded box, a three-dimensional shaded picture, and then you've got 4 options of like flattened out cartons, and the sides are shaded, and you've got to fold it in your mind's eye. And some of them, if you are cranks and pulleys and widgets, and if you crank this crank clockwise, which way will this widget move? It's very exhausting because you have to use both the right and left side of your brain. Most people, their language center and higher centers are in their left, and their mechanical skills are in the right. But you've really got to busy that part of your brain called the corpus callosum in order to do that. So it's very difficult, and it takes a lot of work, and it can be very exhausting. But you've then got to watch and critique the learner like this chief resident is doing with a junior resident in the emergency room, doing this life-saving diagnostic test of a diagnostic peritoneal lavage to see if this person who ran their car into a tree is in fact has internal bleeding in their abdomen. The setup's critical. If you're of like-handedness, like these two surgeons and it's the surgeon here and the student, you're next to each other as you demonstrate. If you're unlike-handedness, I'm right, you're left, it's good to do it across from each other. The practice phase sometimes can be frightening. Look at, it's actually the small guy with the dark eyelashes there that's teaching the big guy how to do this. It's even more frightening because at the time, the big guy was still his boss but didn't have as much experience doing these minimally invasive or laparoscopic surgical procedures. But you've really got to be very careful, give specific instructions, and guide their initial attempts because in a real environment, just millimeters can make a big difference and can result in significant problems for the patient, what we call in the business morbidity and mortality. Either you have a complication and a problem or people can even die. But you've got to then allow for independent practice and make sure and come back that they're doing well and that they've learned the skill. The problem is, in terms of the time involved, is those last 4 steps have to be done with a competent, learned person to make sure that the student or the learner has really come to at least the first level of competence of being able to do it. Again, perfecting phase, here's the residents working up a patient in the emergency room, and the attending's that guy standing up there in the back. And it's, along through the academic year, and he's pretty convinced they know what they're doing, but he's standing back there and making sure that they're doing the right things in the right sequence. So you want to provide for that continued practice, but you've got to watch people do it under as close to real conditions as possible. So the big teaching tip is first you tell them, you show them, you help them, you watch them try, you tell them again and again and again, depending on how adept your student may be. But then you finally got to leave them alone because a lot of people have a lot of performance anxiety and you make them really nervous if you just sit and hover over them all the time. Independent practice is a very important part of the thing. There are some other conditions, and I'll give you some tips of how you might overcome things like the problem of parallax. What I see and you see aren't the same thing. How to brace, how to simplify movement. Visualize it in your mind's eye. See with your mind, Luke, not with your eyes, to know the equipment and repetition. Parallax is that phenomenon that when two people look at something, even though it's the same object, they see something sometimes entirely different, even though their perspective is just 90 degrees different. There can be what I call spatial handedness, or if we're working across the operating room table at a patient and their wound. There's handedness, as we've talked about a bit. If you're left-handed, I'm right-handed, I've got to know that and adjust appropriately. And appreciation takes experience. One of the biggest nightmares is to do a case as a junior surgical resident with a young attending that is not an experienced teacher. And they can make you crazy because they're always fussing at you. Whereas the old masters would hardly say a word. They'd set it up perfect. It was obvious where you should operate. And they'd say, no, a little bit here. Sometimes they wouldn't even have to see, but they knew in their mind's eye you were probably doing the right thing. Here's an example, right? That looks, and many of you have kids play soccer. You stand on the sidelines. And you go, oh, they can't be offsides, right? Or that's an obvious goal between the cones, right? But you change that perspective 90 degrees, it's 6 feet in front of those cones. Okay? So it all depends on your perspective. To those of you familiar with anatomy, you go, well, this is an obvious structure. This is a skeleton that's painted red and blue with the origin where a muscle starts and the insertion where it then ends. And you can see, and I ask people that know this, and I go, what's that? And they go, I don't know. And I go, it's the iliac crest. Come on, it's the iliac crest. But it's just seen from 90 degrees different. This is the side view of that big blade of the ilium of the pelvis. So we're looking at a perspective from here, looking at this thing, see? How different that looks, just 90 degrees different. Or how about this real example? This is take an open cholecystectomy. I'm standing from this perspective, and I'm looking down here in the center of the picture at this gallbladder. Come on back, little arrow. This is the gallbladder, okay, robin's egg blue, and then hurried, pressured attendings telling the resident who's over here on the patient's right to come on, cut, you're too slow, cut. And you'd get impatient with the resident. Well, here's what the resident sees from his side. He can't even see the gallbladder. It's tucked underneath that right edge of the wound. So again, the old master knows what the resident can see or can't see and tries to set the operation not so they can see it, but so the resident can see it. Very, very important. So it's really all in your point of view, and it can vary a lot from side to side. Bracing is also very, very important. There's macro bracing. When we're doing something really hard, it takes a lot of force, like putting a chest tube into someone's chest cavity to drain a collapsed lung. I mean, you take a big guy who weighs 200 pounds, and you're trying to force that clamp through their muscles between their ribs. It takes an enormous amount of force. And those of you who've ever shot a high-powered rifle can probably identify, unless you're braced well, and as the physical therapists say, engaged your core, and check your movement, that clamp, once it goes through that chest wall, is going to go right into the heart. So you have to learn how to brace yourself to do some things, because actually a lot of surgery is actually quite physical and requires a great deal of force. Or there's micro bracing. When you're doing real fine work, you've got to get, and the physicists would say, you're moving that fulcrum closer to your point of action. So in a lever, you've got a moment arm here and a lever arm here. So if you're way here, you've got a lot of mechanical amplification of your tremor, because everyone has a little bit of tremor. So you want to move that fulcrum closer to the point of action. So where's this guy's fulcrum? Where's his brace point? Where's Bobby's brace point? He didn't even have one, does he? It's his, what we call his scapulothoracic association. I mean, the reason a human being can throw a baseball almost 100 miles an hour is that your scapula that has the joint to your humerus, your scapula moves and the humerus moves in the small joint as well. So his chest wall is his brace point. So think of all of the tremor and noise in there when he's trying to sew something as fine as a skin. Now look where his brace point is, right? It's moved right up. He's got his little pinky, he's got his fifth finger resting on the wound, and all he has to do is just lock his wrist and turn his forearm, and that needle will come right through that arc. Sometimes you even move it up closer. Use your opposite hand or use the edge. If you watch somebody either fixing your watch or your hygienist cleaning your teeth, right? You get a rookie dental hygienist, and man, they're skating off of your teeth into your gums. Last time that happened to me, I thought I needed a blood transfusion when I walked out of there. But if I get an experienced hygienist, he's got that heel of their hand pressed against my chin the whole time, and they're making tiny, tiny braced movements. Because in dentistry, they're dealing with, they say a tooth has 32 different curves in it at least, and they're using tolerances and working within tolerances that are really a fraction of a millimeter. So they are the masters of bracing. The other thing is to simplify movements. The less joints and muscles you use, the better you can control the situation. Mechanical engineers call this a noise in a system, and you're trying to dampen down or reduce the noise and your variability. Visualization is another thing. And we teach the resident to see in your mind's eye what you're sewing, to visualize the underlying anatomy, or to think of the trajectory of that curved needle in your needle holder. And one of my favorite senior residents used to tell me, he says, Hugh, it's a very Zen thing. Your whole consciousness should ride the tip of that needle as it comes through its arc. So you really have to focus and concentrate, because when we sew the bowel, we intentionally go partway through its 4-layered wall with each stitch. And we know that that gives us strength, but yet assures good blood supply to where the bowel has to, the intestine has to heal itself together. Athletes do that all the time, right? You see the Winter Olympics and the time trials now, and those luge drivers or those slalom skiers are sitting at the top in the starting gates and they're bouncing back and forth like this. They're rehearsing in their mind with their body all of the curves and the gates that they've got to go through. Okay, so it's very, very helpful. It's been described that there are certain steps in mastery. And the first, when you're naive, you don't even know what you don't know, which was a fairly infamous quote from one of our government leaders a few years ago. How can I know what I don't know, right? But you're unconsciously incompetent. Then finally you're consciously incompetent. You go, wow, that's really hard. That's hard to do. And then finally you go, okay, a lot of people, if I bite my tongue and hold my breath and really think about it, I can do this. And you become consciously competent. And finally, after repetition and practice, you get in, you put the key in the car, next thing you know, a half hour later, you're at work. And you've made thousands and thousands of decisions and corrections and everything that have become unconscious to you. The problem is, when you teach someone a skill, you've got to crawl back up that ladder. And you have to become, in your mind's eye, again, consciously competent, so that you can describe what they need to do and help them through those things. If you're unconsciously competent, there was no learning at all that went on. So you've got to become, again, consciously competent in order to help someone. And the steps to mastery, the progression is kind of clockwise through this, okay? You go from unconsciously to consciously incompetent, then finally you can do it, but then it's natural. But you've got to back up into this box in order to be an effective teacher. So in summary, teaching people technical skills are very important. It's obviously very important in a whole host of things we do. And I think there's a lot of transference, hopefully, for this talk to whatever you do, whether you're a soccer coach or you're teaching somebody how to, change a tire or whatever it might be. Obviously, in my world in surgery, particularly in emergency surgery, it's very important that I help people learn and help impart upon them these skills that will make them a safe and effective surgeon. It's an area of renewed interest now with all this two-dimensional, minimally invasive, or video endoscopic, laparoscopic surgery. It really made us go back and think very carefully about what we were doing, and had fostered a whole new era, again, of more professional education. Not just professional education of book learning and diseases, but also of how to teach people how to do things more effectively with their hands. And hopefully some of these tips and principles will be helpful to you as you go about teaching others how to do things. So, teaching technical skills is something I obviously have to do all the time as a surgeon, because not only do we do, come on up here, have a seat. Not only do we practice medicine as surgeons, but we also have to operate on people, which means, make an incision and you have to sew it up too. I remember I was very proud of myself one time when I was a young boy and I took the alarm clock apart and spread it out on the floor of the living room, and my mother said, I said, look, Mom, what I did, isn't that great? She says, that's great, Hugh, but can you put it back together? So we have to suture people to put it back together. Now, do any of you know how to tie a bowline? Or if you're from the southern U.S., a bowline? No? Nobody does? I need a volunteer then. Who wants to come up here and learn how to tie a bowline? Okay, on the end. Tell me your name now again.
Diana.
Diana, okay. I'm going to teach you how to tie a bowline, all right?
Oh, sure.
Okay, good. You've never done this before?
I don't think I have.
Okay, great, okay. It's easy, and you can do it very quickly, all right?
Do I get to see this, or?
You're awfully particular. You're one of these Generation Xers? I mean...
No, not quite.
Yeah. You can't do that? I mean, it only takes about 3 seconds.
I'm sure.
Okay? I'm going to show you again.
Okay.
All right, here we go. You got it?
I think I'm going to need a little help.
You think you're going to need a little help? What kind of help could she use? Yeah, she could see what I'm doing. That's helpful, right? What else? Slower? Slow it down? You guys can't see very well, can you? Well, neither could she. Help her through it. Break it down in steps. Right. Let her touch the rope. That's right. You can't touch my patient. Okay? So let's try a different way. Okay? All right. So I'm going to teach you how to tie a bowline. It's Ann?
Diana.
Yeah, see? Short-term memory, too, is going. This is a bowline, B-O-W-L-I-N, bowline, or if you're from a bowline, if you're from the South. It's a non-slip loop. It won't slip. So people use this for mountain climbing, for rescues. You know, if you're going to get pulled off your sinking house or your boat by the helicopter, you put a bowline around your waist. So you got the part coming from the helicopter, okay? And are you right-handed?
I am.
Thank God. Okay. So, and you've got the other end in your right hand, right out at the end, okay? And I won't ask you how old you are, but there was an old cigarette ad jingle, over, under, around, and through. It was the, I don't know, Lucky Strike or Pall Mall Filter or something. You're really dating yourself if you remember that one. So it's, okay, right hand, here we go. Over, under, and it's through that loop.
Okay.
Okay? Around this, and then you re-grab it. That's the key. That's the tricky part. So you have to take it around and then re-grab. And then through the loop you made with your hand. Okay? Over, under, around, and through.
Okay.
Want to see it again?
Sure.
Okay. Okay. Coming from your friends from the U.S. Coast Guard.
Right.
Okay? And right out the end of your dominant hand, your right hand. Over, under, see? Under here. Around, re-grab, through. Okay, you want to give it a try?
Sure.
Okay. I'll hold the mic.
We don't have a grade on this or anything, do we?
You never know.
Okay. So, over, under.
Don't grab yet.
Okay.
Keep going all the way through. Okay, now around.
Around.
Now re-grab on the other side.
This way?
You hold on to this.
Okay.
This is the tricky part.
Okay.
You got it there. Good, good. And now through. That is amazing. That's good. Yeah. Well, thanks. Good teaching. You're very kind. But you can see that there is obviously a good way and a bad way to try and teach people how to do a technical skill. How many of you have ever coached a sport? Coaches out there? You know, you got to teach people how to do things. So you have to give them an example and show them how to do that. I'll give this back to you. There you go. Great. So if we're gonna tie with a needle, or we're going to make a little incision in this, okay? And then I'm going to teach you how to suture, and I'm going to teach you how to do an instrument tie. So I want you first to grab one of these, and you need to grab this tape and double back the tape so your patient, your black tape is your anesthetic, so your patient doesn't move, okay? All right? So just rip a piece off, double back it, and see what I did to Diane's there? Patient's not going to move. Okay, and then we're going to give you some instruments. Then you all need a needle holder, and to you, they're tweezers. To us in the business, they're forceps, okay? So here's forceps for all of you, okay? And a needle holder. I haven't forgot you, don't worry down there, okay? And then I'm going to give you some suture. Oh, my goodness. There we go. There are some subtle differences between a needle holder and a hemostat, which, good thing my eyes haven't completely failed, okay? And then I'm going to give you a suture, a package of suture to sew your patient up, and then I'm going to make a cut in each one, okay? These are peel packs. Watch this. See how you do that? And if you're in a sterile environment, you pop that on the sterile field, and then there's no germs on it, okay? So you guys each get a suture. And I'm going to show you how to load that suture up. So just take the peel pack off of it for starters, all right? So step number one, when we operate, you want your forearms to be at right angles to each other, okay? And you want to be comfortable, okay? And you rest. It's good to rest your forearms on something to give you a brace point, okay? You don't want to be like this because you've got to, as the engineers would say, my buddies who build airplanes down there for Mr. Boeing, they'd say you've got a real long moment arm, okay? Are any of you recovering engineers? Nobody would ever admit it if they were. Okay, and I'm going to make a cut. Watch out, this is sharp. We have one rule on our service, one patient per operation, okay? So the rest is gravy after that. Okay, so there's your patient's cut. Watch your fingers now. Yeah, exactly. Yeah, I wasn't going to pass these out, and this is where I cut my finger, so I'm just going to cut that out. All right, there's yours and yours. I made yours wide because you look like a gnarly dude. I think you can handle it. Okay. What's your name? Jake. Jake, yeah. Guy like a name like Jake, of course you're a gnarly dude. Are you a snowboarder, Jake?
No.
That was close. Snowboarder just smacked me if I said something like that. Okay, all right. Okay, so now your patient presents to the ER with a cut, known in the business as a laceration. Okay, sorry. So the goal is to bring those two edges of the cut together, okay? And you're going to do that. So I want you to first load your needle on your needle holder. Now they make these very ergonomic, these packs of suture. So if you hold the white hand, are you all right-handed? Any of you left-handed? Good. Ooh, because that really, and that's what we call a learning needs assessment in the business. Know where you're starting, because if somebody's left-handed, they start to do things, you think, oh my God, they're clumsy. So take it in the white stuff and see the needle poking out the side. So when we're in a hurry and somebody's in big trouble, all we know is we just have to stick that needle holder right up against the green, grab the needle, and it's loaded halfway. Isn't that slick? Very ergonomic. So again, always load your needle at a right angle, just load it up. Now, the ratchet, you haven't worked a ratchet before? Okay, you can put your fingers in a brace point, or you can palm it. But you want to have usually your thumb and your fourth finger and your index right there. So you just go in and grab your needle. All right, see that, like that? About 2/3 of the way back from the tip. Now be careful because that tip's sharp, right? We don't want to violate rule 1 of our service, which is? One patient per operation, very good. Okay. Okay, so we're going to sew through that, and when you sew, you want that needle to kind of go through at right angles into the skin. And I'm going to give you a little demo here, okay? And I'm going to use another one for the demonstration. And you watch me do this. And then you try and do what I do. And I'll give you some little tips. Another laceration here. And take this stuff out. Okay, good. All right. So when you hold your forceps, take your forceps in your left hand. You hold them like chopsticks, okay? Other way. See like that? It's weird. Believe me, it's weird, okay? But that's the way you do it. Okay, good. You are a sharp bunch. So you got to roll your wrist back. You put it in at right angles like a diver would, getting a good score, and then you just roll your forearm up. So with a locked wrist, that's all you have to do, is just turn your forearm, okay? And it's going to just stay put right in the middle of your wound. Try that. And just let go, see? Just let go of it. Go ahead. I forget your name.
Colin.
Colin. Just let go now with your forceps. Just take it off. See how it didn't move? Right? Let me help you down here. Look, see how I have my hand? Go like that. There, turn this over in your hand. Let go. There you go. And go like that. Okay, start that way. Try that. So you can just go in there. And see how when you do that, and you've got your hands at right angles, your forceps are right there ready to help you with your needle. Now there's some fields of surgery where we don't let people, until they're really experienced, grab their needle with their forceps like a blood vessel, because they'll tear it up. Okay, so all you have to do is lock your wrist, and this movement in anatomy is called supinate. Pronate, supinate, but you just turn your wrist, your hand up, and that's how you do it. And see how that needle didn't move? Because it scribed a nice, smooth, perfect arc. Now you take it out, reload it, and go across the other side. Try that. Easier said than done, isn't it? Okay, go ahead and put it in that side. And then you come up in the middle of the wound. That's always easier if you do it in 2 steps, actually. Okay, drop it. Help it with that. And you can use your little forceps here to kind of move it up a little bit. See, like that. And it kind of squirreled on us. There you go. Grab that thing. Good. Okay, now go to the other side.
Inside the wound.
Okay. Watch this for a second. You know the famous last words of a cougar, don't you? No, hold my beer, watch this. Okay. Okay, watch me now. I'll give you a demo. Okay, so we got the needle on there. I'm going to go in, and I'm going to come up right into the jaws of my forceps, and I'm going to move it just a little bit while it's still braced, and re-grab it, okay? I'm going to pull it up to a little bit of length. That's the tricky part, because you always, for about the first 4 years, you always pull that tail through. And then I'm going to do it again, okay? So go through both sides like that, okay? So now at least you got the suture across both sides of the wound.
Can you show how you went to the second side?
Just go through, you're in the wound, so go from the white stuff into the tan stuff. Okay, start at the same depth in the white as you came out on the other side. Okay, so the trick here is to make sure you're loaded right. Okay, see that?
Yeah.
That's a fancy load on the needle. Let me just help you without breaking your thumb. Just let go for a second. I have to remember that sometime. They go, Dr. Foy, you're breaking my thumb. Okay, so you want to see at right angles. Remember that geometry thing, right angles? Perfect square, like that. So that's always how you want to load your needle up. You are doing, yeah, very good. Okay, now you've made well, that's a variation of the theme. That's actually not too bad. But let's just try a simple. This is what we call a simple interrupted. Okay, you see that? And now you pull that up until you got just a little bit of tail sitting up there. Okay? Now here comes the tricky part. Everybody got it through both sides? How are you doing over here, Diane?
Well, I hope the patient doesn't die.
Not bad. Me too. Me too. Okay, that's okay. Let me just show you here again. Let go.
Yep.
Like that. Okay? Right angles. Perfect square. And so always so toward yourself. You are right-handed, correct?
I am.
Okay, so start this side and work toward yourself. Bring your arm around. Rest that elbow. Okay, rest that elbow. Right angles. Ready? And roll. Good, good, good. That's it. Oh, that's beautiful. Okay, now let go.
Okay.
Release the ratchet. That's tricky. When did you graduate from college?
84?
84? You were kind of the post-hemostat era, okay? All right. I know who you're laughing over there, too. Okay, okay. Just go ahead and just release this ratchet. You kind of have to crack it, and it comes off of that thing, okay? That was a little extreme. Okay, now everybody through both sides with the tail on the other side. We're going to tie an instrument knot. So just leave the needle, okay? And you want to keep your needle holder in your right hand and your long, loose suture in the other. okay? And I'm going to do it first here, and then I'm going to give you a big demo. But here's the deal. Where's my rope? Right here. And here's my, courtesy of the neighborhood hardware store, here's my suture, okay? This is the little tail sticking out the other edge, right? Okay? This is the wound. And I'll just put this for a visual aid. That's wound. Okay? You hold your needle holder over the long axis of the wound. Okay? Let me see you all do that. Good. And you're going to wrap over the top of your needle holder twice. Once, twice. It's hard. You got to keep a little tension on it there, Jake. Tension. Okay. Okay? Everybody wrapped around twice. Then you got to go over there and sneak and grab that tail at the end, the other side of the suture. Okay? These kind of squirrel a little bit. So if you take the memory out of that nylon, it works a little bit better. Okay? So again, you've wrapped once, twice, and this is a surgeon's knot. You can just do it once, but it won't work. And now you take your hands opposite. You pull your needle holder towards you, needle holder towards you, and your other hand away, and that's supposed to lay down a nice flat square knot, or a surgeon's knot, okay? So there you go. That's it. That's it. Once is good. Once is good. I'll take once. Okay? So again, let's just do once. We'll make it easy. The thing, if you wrap it twice, there's a little bit more friction. It stays put. Okay? Let me get this suture under control. So you wrap, long axis, wrap over the top, reach through and grab, and pull towards yourself. Okay? See that? And now your hands alternate, 180 degrees every time if you want to do a square knot. Next time, same deal. Needle holder over the top, wrap the other way, reach through and grab. And there, my patient's moving. I yell at the anesthesiologist, give him more. Okay? And there's a perfect square knot. So it's over the top and towards you, over the top the other way, and your needle holder away from you. Okay? Try that. Just wrap, pull one way, wrap the other way, pull, and take your needle holder the other way. There you go. Once is good. Grab the tail. Let me fix that tail for you there, buddy. If you trim that tail, it's a lot easier to deal with. Okay? Yeah, I'll trim your tail. Where is it? Rascal. Okay, you got it good. You got the needle over there in your hand? Yep. There's your tail trim. How you doing? You got it? It's hard, isn't it? It always looks easy when you watch experienced people do it, and then they say, here, you try it. And then your whole world just falls apart. And there's a lot of tricks of the trade, and one of the main one is bracing. You know, you have to know your equipment. You have to do it. You have to learn how to brace. When you're teaching somebody, you have to consider their perspective where they're seeing it from, okay? But again, it's just you wrap one way, and then you wrap over the top, and you go, and you alternate your hands one way versus the other. Whether you're tying doing an instrument tie, or whether you're doing a free tie like you're tying a blood vessel, okay? So watch my hands as I just tie it around my leg, okay? And this is hard. This is really hard. This is without your mother's finger on the package. So I take my hands that way, and then I take my hands the other way. And I take my hands this way, and then the other way. And so see how that makes nice flat square knots? Which really, because they intertwine, it gives you it distributes your tension a lot better. So I think they did a pretty good job for their first shot, don't you? Yeah. Give them a big hand. We're kind of late. We'll take a couple questions.
I would like to ask you how much more frequently nutrition is being introduced into medical school.
How frequently?
The study of nutrition.
Yeah. I can't give you a breakdown in terms of the actual numbers, because that's like negotiating with terrorists in terms of developing the curriculum.
Do you think
I would say I think we could use more
Okay.
I think what we put in our bodies is a lot more important than we once thought. And there's a lot of things that we've come to learn over the years that we thought were okay ideas, that cumulative effect over decades needs to be paid more attention to.
The other question I'd have is, do you see more of a partnership between Western and Eastern medicine in the future?
I think so. I mean, it's amazing, particularly things that we don't understand well as allopathic physicians, right? This business is what we call allopathic medicine, as opposed to osteopathic medicine, as opposed to chiropractic medicine, which are all Western traditions, as opposed to, say, Eastern. People with back pain, for example, how many of them will seek and actually achieve pretty amazing relief with acupuncture, which is a totally different theory of probably what we would allopaths refer to as the gate theory of pain. So I think there's a lot to be learned, and I think as our societies on both ends become more open, we'll learn a lot about that.
Thank you.
You bet.
Feel free to debunk this rumor if it isn't true, but is the number of students accepted into medical schools shrinking?
No, the absolute number is not shrinking. In fact, it's increasing, and our student body at the University of Washington is just undergone an expansion from about 184 now to 216. So, and that's a fraction of really what we need to do. And across the country there, in 1973, I didn't elaborate. President Reagan thought, well, this is supply and demand, so let's just increase the supply of physicians, and that'll increase competition, bring the price down. It was a miserable disaster. They found that every physician went out, practiced, no matter how many there were, everybody generated a certain amount of hundreds of thousands of dollars of billing. But it's pretty clear that we need to do a little bit better long-range planning. Again, we let over 5,000, and at times almost 8,000 physicians trained in the rest of the world into U.S. residency programs. The majority of them are from where? One of the poorest countries in the world? India. Into this country to fill residency spots, because we don't graduate enough medical students ourselves. So stay tuned. I mean, I'm not the only rabid socialist long-range planner out there. There are a lot of people who have thought for a long time that we need to make some improvements. And I think, hopefully, they're on the horizon. Right now, you got about 1 in 4 shot if you apply. But what happens as the economy fluctuates, right? 10 years ago, everybody wanted to go into IT because that was the great thing. The economy's going great, less people apply to medical school. Economy looks like it does now, woof, look out, you know, get out of the way, here they come. That answer your question?
Yes, thank you very much.
You're welcome. Again, thank you very much for your attention. I apologize for going off.